My name is Harris Sloan, and in this video we will be presenting our novel technique for distally based patellar tendon shortening with medial patellotibial ligament reconstruction. We have no relevant disclosures related to this talk. The incision for this surgery extends from the distal pole of the patella to the tibial tubercle. In cases where a coincident medial patellofemoral ligament reconstruction is being performed, such as in this case, the incision starts slightly proximal to facilitate that additional portion of the procedure. Sharp dissection is carried down to the peritoneum, and a small nick in the peritoneum is made, and the peritoneum is incised proximally and distally with Metzenbaum scissors. The medial and lateral flaps of the peritoneum are elevated to expose the medial and lateral border of the patellar tendon. The width of the patellar tendon is then measured. If the width measures greater than 30 millimeters, the central 10 millimeters is marked. If the width measures less than 30 millimeters, the central third of the portion is marked for this portion of the procedure. A 15-blade scalpel is then used to incise the central portion of the patellar tendon in a parallel fashion, very similar to a bone tendon patellar tendon harvest for ACL reconstruction. The parallel patellar tendon incision is carried down onto the tibial tubercle periosteum for about 1.5 to 2 centimeters. Then a transverse cut is made connecting the two parallel incisions, and the distal patellar tendon is carefully elevated off of the tibial tubercle. This can be done with the bow of electrocautery or with a 15-blade scalpel. Care is taken to ensure that the dissection extends proximally all the way to bone onto the patella distal pole. Additionally, you can see the portion of the patella tendon that has been sharply incised off of the tibial tubercle, which gives additional length critical to completion of this procedure. The knee is placed into relative extension. The central slip of the patella tendon is then reflected proximally. The medial and lateral borders of the patellar tendon defect are closed in a side-to-side fashion with figure of 8 sutures using zero vicryl suture. Generally speaking, a minimum of 6 sutures is used to close this defect, and more sutures will result in more distalization of the patella. An Arthrex fiber tack anchor is then placed 1.5 to 1 centimeters medial to the patellar tendon attachment on the tibial tubercle. Modified Mason-Allen stitches and/or Krakow stitches are then placed in the distal portion of the central patella tendon slip. This is then secured down to bone, medial to the medial attachment of the native patellar tendon. This effectively reconstructs the medial patellotibial ligament reconstruction and provides a more medial force vector and lateral restraint to patella tendon translation. The knee is then brought through a range of motion to ensure that there is no patellar capture or over-constraint of the patellar tendon. The edges of the transposed central slip of the patellar tendon are sewn to the underlying patellar tendon with zero vicryl suture. This is done both on the medial and lateral border of the transposed slip, extending from the patella down to the tibial tubercle. As you can see in this video, prior to any medial patellofemoral ligament reconstruction, there is a significant restraint to lateral patella translation following completion of transfer of the central slip of the patella tendon alone. Thank you for watching our surgical technique. We hope that this surgical technique provides you an additional tool for treating patients with patellofemoral instability.